So, yes, discrete trial teaching. So many of us, how many here are working in sort of classroom or working as ABA therapists with children? Yeah. And or some of us have in the past? Yes. So discrete trial teaching is one of those sort of procedures that we all know, that we all, it's probably it's synonymous with ABA, and obviously people think that's all ABA actually is. And there are people out there who sort of say we shouldn't use discrete trial teaching as well. They're sort of saying it's not conducive to learning, the children become robotic and they're responding and things. But there are opportunities and there are times when we do need to use a discrete trial teaching procedure in order to teach new skills. So what that I had basically wanted to research was, you know, as a therapist for many, many years, I was given on-the-job training in discrete trial and thrown in at the deep end. And then when you become a practitioner and a clinical lead, you then have to teach parents and other therapists to implement these procedures too. And when you're working very, very short time periods with people, you need to have something that's fast, but it's also going to be effective. So for one of my PhD studies, we decided that we would try different methods and what would be the most effective to have the outcome of good discrete trial teaching procedures. So discrete trial teaching is an instructional teaching method with its ethos lying in the experimental analysis of behaviour. It's a common instructional technique that has been a part of many EIBI programs for children diagnosed with ASD. And again, as I say, most people who criticise the science will say, look, you have a child sitting at a table and you're drilling them until they respond correctly and you're giving them rewards for responding correctly and things. But we as practitioners know that it's very systematic, especially for children on the ASD spectrum. We teach them how to respond appropriately to certain stimuli, and then we will build on that and they're able to generalise it. So any good program will have generalisation built into it. It's been proven to significantly help with both developmental and educational attainments for children with ASD as well as other developmental delays. And Smith 2001 refers to discrete trial teaching as one of the most important instructional methods for children with autism. Now again, I have worked many years with children with ASD, and there were very competent children who had very high skills, but sometimes we had to implement a discrete trial teaching procedure in order to maybe further develop something or a skill that wasn't in the repertoire. So we had to go back to that tabletop learning, and then we take it away as soon as we can. So the discrete trial lasts approximately 5 to 20 seconds, and trials are presented rapidly to maximise the learning opportunities in each teaching session. So again, there are people who say, and arguments that, oh, you have the child sitting at a table all the time, but any discrete trial procedure, as we all know, is fast, and it's done in a fast-paced manner, and it's child-led, so the child's responses will actually tell us what our next response should be to them as well. So each trial consists of 5 components. So you've got your discriminative stimulus, so your instruction, okay? You have the prompt, which is optional. Again, so when we issue a prompt, it could be following the introduction of a new target. It could be following an incorrect response. But again, that's an optional prompt. Once the child or the learner has mastered the skill, prompts are used less and less within the discrete trial procedure. The learner's response, so we can have a correct response, we can have an incorrect response, and we can have a no response. We would still record a no response as a response as well. We would also have the consequence, so this would be well done, positive reinforcement. It would be an error correction procedure, something like that there. And then you would have the inter-trial interval as well. Again, this is maybe for you to get the next materials ready. It's also for maybe the child to have access to the reinforcer if they're working on specific high levels of reinforcement initially. A high level of precision is required to implement discrete trial procedures well. And I'm sure that some of us will have seen very dire implementation of discrete trial procedures, and lots of inadvertent eye prompting, lots of eye gaze, lots of give me, and you're so excited that you want the child to respond that you're given that inadvertent prompt right away. Materials being presented incorrectly, not providing reinforcement appropriately, not engaging with the child or young person while they're waiting at the table. So there are lots and lots of errors that can be appear within a discrete trial teaching procedure. And what we find is many staff members and parents struggle to achieve the high levels of procedural integrity because maybe they're implementing it, just having watched the video, or someone has given them a quick lesson on it as well. So when it comes to problematic behaviours that often arise within a discrete trial, maybe people aren't equipped. So again, when I was taught this, I wasn't shown how to deal with any problem behaviours. So when it was the child sitting at the table, they responded appropriately, you provided the reinforcement. If they responded incorrectly, you implemented an error correction procedure. Nobody prepared me for the child that threw themselves onto the table. Nobody prepared me for the child who swiped all materials off the table, who didn't respond, who engaged in self-stimulatory behaviour with visuals and things like that there. So again, this is something that we'll talk about later that we're working on as well. So incorrect implementation of the discrete trial could lead to faulty stimulus control, artificial skill mastery, where the child appears as well to have gained and is fully competent, and that's fluent in their repertoire. However, again, if you maybe do a probe test on that, you will see that maybe the child has been using IQs in order to respond correctly, or materials haven't been rotated on the table. They've always been presented in the same order. So again, this leads to this artificial skill where, yes, they've mastered that, let's move on to the next target. Prompt dependency. You can get high levels of prompt dependency if we do not fade out our prompts quickly enough whenever the trial is in place, and once the child has understood how they're supposed to be responding. And then you can get the problem behaviour. The first time that happens to you, when you're out in the field by yourself, it's a bit of a shocker, especially if the problem behaviour is a challenging type one where you're physically attacked. Just going through your simple issuing your instruction and then the child comes across the table, you're not prepared for that. So again, these can all impede on the learner's progress as well, because we maybe have to work on reducing the prompts, we have to work on the challenging behaviours, we have to make reinforcement get provided at a higher level in order to reduce these behaviours. So several variables can negatively impact the quality of discrete trial training delivery. First, the therapist for children with autism must be competent and fluent in the delivery of the DTT under stressful conditions. So how many of you here who have implemented any DTT procedure were you thrown in at the deep end as such and they deal with these on the hoof? Yeah. And again, this is where all your training comes into play, isn't it? Where you're like, oh, I can't reinforce that inappropriate behaviour. However, when we're expecting parents, when I was carrying out this experiment, I was expecting parents to complete this and to deal with the behaviours at the same time as well. Second, the typical levels of education and wages in early EIBI settings are low for the level of required instructional precision. So we get high staff turnover. So we maybe have therapists coming in to work in family homes who are maybe halfway through their masters and they're paid, or they're volunteering and then they leave because they've been offered a job and things like that there. So once they get that level of fluency, we then have to retrain other people coming up the ranks. So it's always that constant high staff turnover, especially for home-based ABI programs. And it can be costly due to the extensive training required to prepare a new staff member to effectively implement the DTT procedure. So again, parents then have to pay for more training. Settings have to pay for more staff to be trained as well, and then maybe we have procedural errors passed on to the next person as well. So due to the aforementioned high turnover, it's prudent to therefore train parents and caregivers in the successful implementation of DTT. So for those of you who don't know my background, I spent 10 years in sort of applied setting in a charity, working directly with children and parents who were diagnosed with ASD. And they were doing home-based ABA programs. So initially, when I went in for 2-year-olds and maybe a wee bit older at times, there was a lot of DTT and there weren't enough therapists to come in and work directly with the family. So our goal was to train the parents successfully. So a number of studies have evaluated the impact of teaching parents to children with ASD to implement them. So again, this is the way we're going. Because of the lack, particularly in Northern Ireland, we don't have the schools, we don't have the centres that they would have in other parts of the world. We want to train the parents so that they're proficient in doing it. And it can be done, but it does take time and it does take effort. So there were a number of different teaching methods that the research has suggested. So combinations of behavioural skills training, video and in vivo DTT sessions, role play and feedback and correct implementation of the DTT procedure. So I do any of these within my session and I leave thinking, brilliant, the parent's going to do it. when I go back again, there's procedural errors. The data maybe doesn't reflect the actual ability of the child. Maybe the child has stagnated because the parent is unsure how to move on to the next target, or they don't want to make mistakes. So the child is, who maybe was sitting at accuracy levels of 100% is now down at 30 due to boredom and things like that there. So we need to plan for all these when we're implementing any DTT procedure and training. So it was noted by all of the research that these methods were both time intensive and cost intensive in order to ensure competency, with some taking 25 hours to reach that competency, whereas others have taught it in a 10-minute session as well. So it varies from whatever procedure you're using as well. The presentation of information can be overwhelming for parents of a child with an ASD. And if you're saying to them, this is how I want you to present that, and always you're making them become the teacher, it can be very daunting for them. So it's up to us to identify what is the best way, what is the least pressurised way for the parent, but least time intensive for them as well, that they can successfully go about it. So that's why we're saying, what can we put into place to see what's effective and not as time intensive. So the present study, the purpose of this study in particular was to compare 3 different procedures for helping identify errors within a DTT procedure. So due to ethical limitations that I had throughout my PhD, I was never ethically given permission to collect any data on the behaviour of the children. So I was only ever allowed to collect data on the behaviour of the parents. So in terms of how I can say how this was implemented and how the children gained, I can't. I can informally and anecdotally report, but I have no formal data for that. So research to date has focused on the error correction procedures that are used for incorrect and non-responding behaviours. So do we come in with a no-no prompt right away? Do we use 3 stimuli on the table to reduce the errors? Or do we go down with the one and we go through the mass trial, distractor trial and random rotation stages of it? So what we were sort of hypothesising was, by teaching parents to identify the errors that occur within sessions, there's the potential that in a natural context they should be able to address them and successfully implement a DTT session. So rather than teach them the perfect session, we were using sort of lessons based on that, and then they would go and try and identify errors within other videos, and they could say that was implemented incorrectly or that wasn't done, so that when it came to actually putting into practice for themselves, they were more aware of the potential errors out there. So rather than procedural, we were working on error identification. So in the first experiment, I've got you all hooked now because it says first experiment, 3 procedures were examined. So they were a simple textual description of DTTs. So what we wanted to see was, in terms of teaching, what should we be using in order to teach people? Do we rely on traditional PowerPoint? Do we rely on, go and read that journal, go and read that, and you should be proficient and off you go? So again, we just want to see is if there's a more efficient and less time consuming and more advanced in terms of technology that we have now, could we change how we teach? So we also had a PowerPoint describing the features of the procedure. Again, this is more the traditional method of how we would teach. Even here, we rely quite heavily on our PowerPoint presentations to get information across. And then an animation that was showing the DTT procedure. So across all of the procedures, basically the same script. The script that we used was used to build the animation. The script that we used was used to build the PowerPoint, and this was the actual script that they were using in order to follow it. So they would read that script, then they would watch the videos. They would watch the PowerPoint, then they would watch the videos and things and so forth. So participants were selected from a group of parents of children with confirmed or suspected diagnosis of ASD. So again, these were families that I was working with who had initially just started their home-based program, or had maybe had 1 or 2 introductory sessions, so they weren't proficient in understanding about discrete trial teaching as such. So they were fairly new parents to ABA and practice. They were about to start, as I said. The inclusion criterion was utilised in order to ensure that all participants had minimal or no knowledge of the DTT. So I wanted to get in there when they were quite fresh and hadn't any preconceived notions of what they were doing. 10 participants consented. We had 5 in the first study and 5 in the second study. And due to the time-intensive nature of the study, the setting was in their own home. I had probed this in a university setting with a group of master's students. And because everybody was working on different of the procedures independently as well, it could not be done in a group setting. So it was decided then that we go down the route of individualised training, just due to the high nature of it, and they had to watch the thing again. So it was too time intensive to do it in a group, and it worked really well in a one-to-one setting. So procedure 1, these are the materials with simple steps. So how many of you know about simple steps? Yeah, good. It's good to hear. The first procedure was a media-rich animated lesson from Simple Steps on implementing the DTT procedure. This wasn't in the original pack of Simple Steps when Simple Steps was first developed. This came on the back of further development and further interest from parents and settings that DTT should be included. And it was presented as 3 individual videos. So it was interspersed with Neil Martin of the BICB talking about the session, and then it going to animation where someone would walk around the room and they would use animation within the videos as well. The videos began with the behaviour analyst in vision and then how to prepare. So you had getting your materials ready. Again, you'd be surprised at how many people make that error where they're trying to find materials as they're going, and where's that, and where's my tokens, where's the reinforcer. So it was given all those steps to begin with. And as I said, the videos are interspersed with animations, allow those to watch and to see individual steps of the DTT. The reason the animation was good, it could show angles that perhaps you couldn't get from a PowerPoint. So it could show utilising hand-over-hand prompting, where you position the materials on the table, things like that there. It was also able to put in being aware of eye prompting and inadvertent eye prompting just by the angle of the animation. So it was something that traditional PowerPoints maybe couldn't cope for, and when you're reading it from a script, or like as we would say, like a journal article, you have this image, but until you see it, then we'll see how it works. So here's just a snippet of the video that was used with one of them, one of 3.
Before we begin using discrete trial teaching, we need to prepare our data sheet. The first thing you will do is write the name of the program, the skill being targeted, at the top of your data sheet, alongside the time, date, and the name of the child. In this instance, it will be colour identification. When you and the child are ready and the materials have been arranged, you can give a verbal instruction. For example, give me green to the child. See the example here. Next, we enter the stage of the program being used. Discrete trial teaching is typically taught in different stages and generally begins with immediately prompted trials. These are usually called mass trials, MT on the datasheet. The goal is for the task to be easy to understand. These prompted trials only involve the target item with no other items present. Although it is important to move the target item around rather than always place it in the same position. The number of responses to successive teaching trials is recorded to be able to check the number of correct and incorrect responses on the part of the child. At this stage, we want to see 100% across several sets of trials for correctly prompted responses before considering moving to the next stage.
Okay, so as you can see, I wasn't going to let Neil talk there, but that's one take, Neil. He did all that in one take without any errors. So that was great to hear. But their animation, in a way, for parents is very good because it goes through step by step. And if you're leaving a parent after visiting, not seeing them for a few weeks, they can refer to that video again and sort of shape up their own skills with the DTT session. As I say, the videos, there were 3 of them. They subdivided them into 3, and they can range from 5 minutes to 11 minutes. So you can see why in a group setting, if everybody was working to their own targets, it would be quite difficult to implement. So then these are just screenshots, as you can see. There's the eye prompting there where the animation is showing that the therapist is inadvertently leading to the correct response for the student. And then they have some graphs and things like that there. And then they have student response. It's a nice animation of how it should be implemented. And again, I think if it was used properly and correctly, it would work really well for teaching it independently. So procedure 2 was the PowerPoint. The second procedure, PowerPoint on how to implement. As I say, the same script was used throughout, so to keep the continuity of all the procedures. Explain systematically how to implement the DTT in a concise, simplified manner. and it utilised both graphics and text, but no video was included. So, your traditional PowerPoint, so this is your sort of error correction procedures you would implement following incorrect or correct response and what we would provide. As I say, that's our traditional way of teaching. And again, we have to see if it's effective. And then you had the script, and as I said, it was used for both the PowerPoint and the Simple Steps animation. So, the media-rich animation, the PowerPoint and the text were counterbalanced across the three conditions for the participants using within subjects Latin square design. 6 videos were recorded by the researcher showing mock DTT sessions. Okay, so what we did was, again, because I was ethically unable to record any data showing or any video showing children, I had to use myself and another behaviour analyst, and we role-played DTT sessions where we actually had deliberate errors within there based on what the most common errors were. The errors included inter-trial interval too long, reinforcement not appropriate for the response, accepting inappropriate responses, the SD not being clear, ineffective use of prompts, etc. So all the ones that we would do and we would see most often when we're in practice, these are the ones that we sort of targeted. And each condition then was paired with a set of videos. So we had 6 videos in total. So for the first experiment, condition 1, the animation condition was paired with video pair 1. So they had a certain set of videos, certain set of errors within those. For the PowerPoint, they were paired with video pair 2. Again, 2 videos showing different errors, but maybe the same, but they're presented in a different way. And then we had the text condition, which was paired with video pair 3. So again, each participant had to go through each of these and watch all 6 videos, and they would have to watch them until they were able to identify the errors. So an alternating treatment design was used, and this would help determine whether one of the procedures was more effective at teaching participants how to identify the errors. So each participant experienced all 3 procedures, but were randomly allocated in how these procedures were presented to them. Baseline data were collected in each participant's responses after watching video 1. So, show me the errors. It was as simple as that. Or tell me the errors, or can you tell me how many errors? They had to write down the errors that they had identified, and then that was our baseline. So we were able to see where they were and compare it later on. So each condition was then presented to the participant based on the allocated presentation for that particular participant. And again, they were told, condition dependent, to either watch the animation, the PowerPoint, or read the script. So that's, it wasn't brilliant, but it was really effective. So following this, they were presented with 2 videos from the previous, what I showed you, depicting a mock DTT session and asked to identify the mistakes. They then recorded the errors that they identified within the videos. Because it was individualised based on them, they were able to watch it as long as they could. So then they took as long as they could to identify the errors, and it was only when they correctly identified as the 100% accuracy within the videos that they were able to move on to the next condition. So it was very stringent, even though I didn't tell them as we were going through, oh, you identified that error and that error. I would just say you have 70% of them identified across the 2 videos. We need to keep going until they get 100%. And then they would maybe watch the condition again or engage in the condition again and then watch the videos and identify them. Following this, subsequent conditions were introduced, and based on the videos and the parents' identification, inter-observer reliability was found to be 80% as well. So, because there was so much data, my supervisor said to me, look, you would overwhelm. In my thesis, we do have each person's individualised graphs, but for the purpose of any presentation, it was better to show this. Can you tell me, just based on that visual representation from the first experiment, which condition is more effective at helping parents identify errors? Faster? Yeah? The animation? As you can see, can everybody see it okay? Yeah. If you see the text, it took longer within each of the text with the pairings to see. So sorry, I should explain the way it's going. Okay, so we have the assessment pair 3, assessment video pair 2, and assessment video pair 1. Within this, pair 3 was paired with text. And this was each person, MR. There's how many times it took MR to reach mastery criteria within that. BT within that condition. But then when you compare MR with text and her animation, You can see there's a difference. She achieves the mastery criteria much quicker. Yeah.
So what do you mean by pair 3? That's just
that's the video. So if yes, so the videos of pair 3. So they had 2 videos. Pair 3 was paired with text for this particular experiment, and pair 2 was paired with the PowerPoint. So they were watching different videos depending on the condition they were engaging in at that particular time.
Sorry, can I just clarify it in my own head? The baseline was them using all the 3 types of teaching.
No, they had no teaching. They were watching. Yes.
Just watching videos.
Yes, they had to watch one video and identify errors within that particular video.
They were randomized to each of the teaching
Yes.
methods.
Yeah.
They were randomized to one of the teaching methods.
Yes.
Only one.
Yes, one initially, and once they reached mastery in one, they went on to the next one. So they actually met all of the 3 conditions, so they engaged with all of the 3 conditions, and the goal was to identify which of these conditions was basically superior in helping identify errors within the videos.
So there is also a difference in the sequence of the conditions
Yes.
they are exposed to.
Yes. So I'm going to show you now what I mean. So I hit this one. Oh yeah, sorry.
So did you randomly pair the videos to the teaching? Were they the same difficulty and you just
randomly assigned them in the same difficulty, and then that's where experiment 2 comes in, because we would say, well, it was the videos that actually helped make the animation more superior, so then we actually randomised the presentation of the videos again to different conditions, but again, due to time constraints, ideally I would have loved to have run them all with the different conditions, but I was coming that close to submission, I couldn't.
How many videos, sorry?
Six.
Six. They presented one video at a time?
Yes.
In a trial?
Yes, yeah. So they watched the videos, so they engaged with the conditions, say they watched the animation, then they watched the videos, and they had to identify the errors within that. Okay? Any other questions? No?
Sorry, what was the level of education for the participants?
They were parents, some of them had degrees, some were working mothers, so again, they were they were just their parents. They had that one thing in common. They wanted to engage with an ABA home program. So there was no, it wasn't based on their level of their ability or anything. These parents had contacted this organisation themselves because they'd heard about ABA and wanted to utilise it in the home for their child. So again, I had worked, because I'd worked for so many years, I'd worked with parents of different abilities. And again, you'd be surprised at even the levels within that parents grasp so much, when it's explained properly. And again, this was showing that, we have CF in particular was a lecturer within a university, and she was coming in blind, as was the other 4 participants. Okay. So there's all 3 conditions. As I say, we could have put up all the lovely graphs that I do have, and they're available if anybody wants to look at them. But for the purpose of this, it was just easier to show it this way. It doesn't show how the actual sequence of conditions for each participant, okay? So all I have done is group them into the particular conditions. So it might be that BT was exposed to the PowerPoint first, but again, all I want you to see is which one is more superior at helping identify the errors, okay? From the results, it's clear that the text condition with video pair 3 took the longest for identifying all of the errors. Is that what you would have expected?
Yes.
Yeah, good. Averaging the results of this condition, it took 25 sessions for participants to be able to identify the errors. So that's how long it was taken. So if we're going down sort of traditional methods of teaching and saying, like, I want you to read this, and then I want you to perform, it's taken so much longer compared to showing other ways of doing it. So the trends for the other 2 conditions were quite similar, but the animation condition appeared to be superior. 10 videos with the animation compared to 14.4 viewings of the PowerPoint. So again, this was sort of saying to us, well, should we always be reliant on this? Should we always be reliant on students or learners to just go and pick up a book and expect them to engage in this? We need to start thinking with technology that we have and the advancement of it, what we should be doing. So results show that the animation was generally more effective. The text condition was generally the least effective way of teaching. So although conditions were randomly allocated, the videos of the mock DTT sessions were not. And each condition had its own pair that was paired. So this is where if any of you know Mickey got me thinking, and he was like, and he says, it's in front of you, you need to think about it. And this is what we said. So it could be argued that the generally poor performance with the text procedure arose because of the video pairs that were used. And that is a valid argument. We could say, well, those videos were that wee bit harder when paired with the text. So again, we decided we would then flip the videos about and pair them with a different procedure to see if that we would have the same results. So again, the same, we had 5 new participants then who would come on board for this. Same conditions, exact same procedure. It's just that the video allocations were sent to a different condition.
Sorry, the next question. You mentioned that's an alternating treatment design.
Mm-hmm.
So did they first finish teaching with one condition and then moved on to the next?
Yeah.
Or did you alternate by session? Session 1?
Yeah.
Session 2?
It was by session. Yeah, it was by session. No, it wasn't, yeah. Okay. So again, because of time and resources limitations, we had to text. We would have done all 3, but wasn't available. So to examine whether the presentation of the mock DTT videos impacted on the results, it was run again with 5 new participants. And instead of having animation, video pair 1, 2, 3, we allocated them to a different procedure to see if we would get the same results. What do you think before I go on to the next slide?
You replicated your results.
Let us see. There we go. As you can see, okay, there is a little bit more where it's not taking as long. And look at this particular one, RMG didn't take as long to master within the text condition. But you can see the results are generally the same in that the animation is the superior procedure for helping the individuals.
That's 4 different participants, right?
That's 5 new.
Sorry, 5
Yeah,
new.
yeah.
New participants?
Yeah.
Okay.
So we used 5 new participants. So we had 5 initially, and then we used 5 again to see if we could replicate just changing the condition or the video pairing. So again, all 3. Similar to before, this table does not show how the actual sequence of conditions for each participant, but it helps to make comparisons of the effectiveness of each procedure. From the results, it's clear text with video pair 2 this time took the longest as before. So are we saying the text is an effective, time-efficient way for teaching a new skill? No. So even with that, it started to get us thinking differently about how we present information. Averaged in the results, it took 21.2 sessions within the text, slightly less than the 25 of the others. So maybe the videos were a wee bit easier for that, or the just participants were a bit more, they were able to grasp it a bit quicker. The trends for the other 2, PowerPoint and animation, were quite similar, but the animation again appeared to be superior, averaging 11.8 viewings compared to 15.4 for the PowerPoint. And these were slightly higher than those from the previous participants. And we have these 2. 2 of the participants, RMG and LT, performed better in the PowerPoint condition than they did in the animation. So again, maybe that was just they're more visual learners in that respect, and they take more information in with a PowerPoint presentation than they would with a visual. So again, I would love to have gone on, but I had to submit. So the first condition that RMG was exposed to was the animation. So it could be the presentation of how she was exposed to the conditions. So she was already au fait with the animation. So when she went on to the PowerPoint, it was a lot easier for her to identify the errors than it would have been. So it could be, so we go straight in with animation and we get them to implement, because that would suggest that even with that, the animation has a knock-on effect and then the further procedures. So previous research has shown that video modelling has been successful at teaching novice instructors to implement DTT. We would then say that the likes of the animation is in effect like a video modelling procedure using animation, because again, if we're going to model inappropriate or challenging type behaviours, it's going to be difficult. So through the use of animation, that's a new type of video modelling that we could then utilise with parents and children as well. The animation could, as I say, based on technological advances, be considered another form of video modelling with voiceover and in-vision instruction. The animation was very explicit in how a DTT procedure should be implemented and was able to animate angles of the discrete trial that you couldn't really get with filming or describing in a text. Also, I'm sure many of you will agree with this, behavioural terminology can be, for a novice learner, difficult to grasp. So when we have it where they can watch the animation over again, and then it's followed up with, here is how it's actually done. You're supporting that information that they've just listened to Neil talk about. So utilising an animation could reduce the probability of complex behavioural language being misunderstood, potentially reducing the efficacy of the procedure. So they differed from previous research in that participants were not expected following the training to implement a DTT or to be assessed utilising DTT. Ethical, I was not allowed. Okay. The aim was to assess which condition was more effective at helping non-trained participants both understand the three-term contingency that constitutes the structure of the discrete trial, as well as identifying the condition that was least time intensive so it could be effectively implemented in a community-based setting. So again, this was supporting the use of simple steps as a teaching tool as well for parents. So the limitation was that due to limited time resources, different pairs of videos could not be tested across all conditions. So if anybody is interested, I have them all there and they can go off and do it if they want for a bit of fun. And upon initial results, when the condition was found to be superior at helping identify errors, it was hypothesised that perhaps video power 1 was easier for participants and it was not the animation that was effective. So by allocating them to a different procedure, we were able to say, no, that's not the case. Future research may wish to allocate video pairs to all conditions, and as the findings were consistent because of the 2 studies with the 10 participants, it suggests that results were because of the condition, not the video pair itself, so which is good. So they raised potential research questions about the validity of what we teach. It's been demonstrated that adults learn differently from children. However, the teaching methods used in the classroom often don't reflect this difference, okay? So what we're saying is, Keenan said, the design of our training communication material is overly reliant on the printing press, which we are. We like to give our students information, let them go and process it again, but there are other methods now that we can use in order to help teach complex skills and complex new learning. In fact, it goes so far as to suggest unless we explore the limitations of the traditional printing press, we will find ourselves limited in the creativity we use to enlist other technologies that could facilitate better the dissemination of important practical skills. So us as applied behaviour analysts, we should be making it that the community, that we can bring the science to the community, that we can then teach other people to implement these procedures that we talk about, but that we can keep that standard high. So by using other methods rather than just telling, because someone tells me to do something doesn't necessarily mean it's going to equate to me actually practicing it. But if we have all these things at our hand, we can actually teach new skills very rapidly. So further developments, this is one that I'm working on at the minute, and once it's done it will be freely available for teaching. It's going to be there. It's basically a discrete trial and we're using animation and more role playing. And as I alluded earlier, it's to do with errors. So we want situations and how we can help practitioners who are going in to do DTT sessions and the student they're working with doesn't behave in the way that they're supposed to behave, because again we're dealing with real people and they will have their likes, dislikes and their wee moods. So we would have these where we're working through like a PowerPoint presentation, but it will be interspersed with video. So it's what we need for getting ready. Then we would have sort of videos here.
Get ready. Point to blue. Great job on the blue.
So we're using more and more video based with so that we have those good angles. So this is, it looks messy at the minute, okay, but we will be fixing it. So each sort of antecedent is going to be paired with a video that will then be paired with a behaviour, and then it will be what you should do instead of what you shouldn't do. So we're going to be showing the inappropriate responses first.
The child is on the floor away from the table playing with some reinforcers. The therapist, who is sitting at the table, calls him over. Come sit, and the child continues to play, ignoring the request. The therapist gives the instruction, come sit, once again. Again, the child ignores the request and the demand is removed.
So it's very, very simple, but again, practitioners, we will see a lot of people engaging in when they're, oh, okay, don't worry, oh, you're hitting, here, take another toy. So what we have done is we have recorded videos of all of these potential scenarios. We've also recorded videos showing what the therapist shouldn't do, and we've also recorded sort of what they should do under these different circumstances as well. But once that's complete, that, as I say, that will be freely available for everyone. So on that, I would like to thank you for attending and thank you very much for your questions. We are done. Thank you.